Welcome to today's webinar. County Health Rankings and Roadmaps is a program of the University of Wisconsin Population Health Institute with support from the Robert Wood Johnson Foundation. This webinar is produced in collaboration with Healthy Places by Design. The University of Wisconsin-Madison occupies ancestral Ho-Chunk land, a place their nation has called Dajo since time immemorial. Today, UW-Madison respects the inherent sovereignty of the Ho-Chunk Nation, along with the 11 other First Nations of Wisconsin. This webinar will be recorded. All speakers' views are their own. Guest bios and slides from today's webinar are available on our resource page. We will share a link to the resource page when the webinar begins. Stay up to date on all things CHR&R. Find us on Facebook, Twitter, and LinkedIn. And if you haven't already, sign up for our newsletter by scanning this QR code with your phone's camera. It's the best way to find out about upcoming webinars, our podcast, and our latest tools and resources. Your facilitators today include our host, Erica Burrows-Girardi, with support from CHR&R Communications Specialist, Tommy Jaime, and the Collaborative Learning Director from Healthy Places by Design, Joanne Lee.
Welcome to Getting Ready for the 2022 County Health Rankings release. Hi, my name is Erica Burrows-Girardi, and I am the Senior Outreach Specialist at County Health Rankings and Roadmaps. I hope you are excited for the County Health Rankings. I know my colleagues and I are, so let me introduce you to them. I want to start with introducing you to Joanne Lee with Healthy Places by Design. Hi, Joanne.
Hi, Erica. I am definitely excited about today's webinar, and folks in the audience, you are in store for some really important updates from the County Health Rankings and Roadmaps team. Today, I am going to be monitoring the Q&A box, so I encourage you to go ahead and open the Q&A box and feel free to chat in questions as they come up as you listen to our three wonderful presenters. You don't have to hold your questions till the end, and we will try to address as many of the questions either in the Q&A box or during the live Q&A portion today. I want to let you know that Molly Burdine with County Health Rankings will be joining me in the Q&A box, so you may see her name there helping to address some of your questions. Molly is a project assistant for the rankings team with County Health Rankings and Roadmaps. So now, folks, I want to introduce you to Tommy Jaime, and he's going to tell you a little bit more about who he is and how he's going to support your engagement with the chat. Hi, Tommy.
Hey, Joanne, thanks. And hi, everybody. Like everyone else, I'm really excited for today's webinar as well. And like Joanne mentioned, I'll be chatting with you all in the chat box today. And just a reminder that when you're chatting, please be sure that you use the drop-down box and choose chat to everyone before you send your message. And that way everyone can actually see your chat. I'll actually kick the chats off today by asking you to take a moment to let us know what you thought of our new pre-webinar video that we just debuted. Now, if you have a question, like Joanne said, please be sure to place it in the Q&A box where Joanne or Molly will help you out. Next up, I'd like to introduce James Lloyd. James is a colleague here at County Health Rankings and Roadmaps, and he'll be helping with technology. And if you have any tech issues during the webinar, please let us know in the chat. Hey, James.
Hi, Tommy. Thank you so much. And as Tommy said, I'll be watching for technical issues that you might be having, and we'll do what we can to resolve them. I'm so excited about this season at County Health Rankings and Roadmaps, and so I'll hand it back to you, Erica.
Thank you so much, James. And I'm seeing those chats come in, Tommy, about the webinar video. The pre-webinar video, folks, it was just a way for us to introduce who we are. And so you didn't miss anything. If you came in a little late, it's fine. The same information will be on the PDF of the slides that Tommy will let you know how you can access. So for those of you who said you like it, thank you. And so, and some of you are new to us. So for those of you who are new to County Health Rankings and Roadmaps, I want to take a moment rather to introduce our goal. County Health Rankings and Roadmaps is committed to growing community power to improve health equity. And we ask that you join us in this effort. Therefore, we share data so you can identify who isn't thriving in your county. Then we point to evidence to share research that's showing what's working to improve health equity. We also share guidance to help you take steps to action. And lastly, we offer stories to give you real life inspirational examples of what equitable change looks like. CHR&R is comprehensive in that our goal is to provide you with tools and resources to move from data to action. So in the end, everyone has the opportunity to thrive, no matter their zip code, the color of their skin, age, or any other aspect that makes us unique. So Tommy's chatting a link to how you can learn more about who we are and what it is that we do. So I just want to also take a moment to thank you for making the commitment to achieving equity in your community. And like I said, we're here for you. We are committed to providing you with tools and resources. So just like Joanne said earlier, you're in for a treat today because this entire webinar is going to feature new tools and resources for you to deepen your equity work. And I'm actually wearing my CHR&R orange. I hope it looks orange to you, but I am so excited about this webinar. I just had to put on some orange today. And we're going to start with the new data measures for 2022. Our very own Christine Maganda, our data and analytics team leader, is here to tell us all about it. Now, some of you've met Christine before, and she always has such great information to share. Welcome back, Christine.
Hi, Erica. Hi, everybody. I am so excited to join this conversation today.
Thank you. And I can't wait to turn it back to you so we can learn some more. But next, we're going to move to evidence and explore new equity-centered tools in what works for health that's going to help you choose appropriate strategies that meet your community's context. So I'm excited to have the leader from our evidence and policy team share those new tools. Please join me in welcoming Michael Stevenson. Hey, Michael.
Hey, Erica. Thank you so much for having me today.
Absolutely. And lastly, I want to introduce you to Beth Silver. Beth leads the CHR&R's newest team, the Community Outreach and Engagement team. And she's going to be sharing a new way that you can hear from some of the nation's most foremost equity strategists. Please join me in welcoming Beth Silver.
Hi, Erica. Thanks for having me. Excited to be here.
Absolutely. So thanks to Christine, Michael, and Beth. And I hope you're ready to start digging into all of this great information. So I'm going to ask Christine to come on back to the mic and let's get started with data. Christine, let me ask you this. What is the purpose of the county health rankings?
Yes, let's go ahead and start there. At County Health Rankings, we believe in a future where everyone has opportunities to be healthy and thriving. And there are many factors impacting how long and how well we live. County Health Rankings data show how these factors shape community conditions, while also highlighting some really stark differences in health that we can see stemming from historical and current injustices, which create barriers to opportunities in certain places. Our goal is then to use these data to point communities toward resources that can inform action toward better health for all. You know, the first county health rankings were released in 2010, so this release is rounding out over a dozen years of data toward action.
Oh, yes. And I remember the first year that the county health rankings were released. And some of you in the audience may remember that first release as well. So tell us what goes into the rankings. Like, what do all of these community data include?
Let's sort these data into a couple of different categories. For each county, we summarize data on the demographics to describe the makeup of a community according to characteristics like age and size of the population and how rural the county is. We also provide data on the health outcomes experienced by the people living in the county. how well and how long are the people living there. This is where we would calculate measures such as life expectancies and mental health experiences. We sometimes talk about health outcomes as today's health. Then there are many factors that impact future health as well, and we've sorted these health factors into the following categories. Health behaviors might be those types of factors that many people think about first when they're considering what might impact future health. These are things like health behaviors could be something like a measure of diet or exercise, tobacco, just to name a few examples. Next, access to affordable, timely, and quality clinical care is another important factor shaping future health for our community. Then we have social and economic factors, and these include things like education, income, community safety. And these are the types of things that give us that type of social support that we need to enable healthy choices, to afford medical care, to afford housing, and to manage our stress. Then we have the physical environment, and this is where communities live, learn, work, rest, and we interact with our physical environment through so many ways, through the air that we're breathing, the water we drink, the houses that we call our homes, and then the transportation that we use to access work or school, to get our groceries, to visit our friends. All of these are pieces of the physical environment and can open opportunities for better health in a community.
Yeah, and what you have described is actually the county health rankings model. We see it here on the screen, and those of you who are familiar with it, you could probably hear her describing it when she was talking about the different ways that we experience health.
True, kind of the county health rankings model in words. And
Right.
when you visit countyhealthrankings.org, you can explore our model and see how all of these many factors influence community health. Exploring the different health factor areas like social and economic factors will let you browse all of the different measures of health available for each county. So in this example, you'll notice that some of these measures contribute to the overall county health rank within the state, like these measures of children in poverty and income inequality, and others marked with an asterisk provide additional context for communities in evaluating their health. But this particular subset of additional measures does not impact the county health rank.
Yeah, got it. Christine, we know that COVID-19 sadly has impacted communities across the United States. How has the pandemic influenced any of the data that will be released in 2022?
The pandemic has influenced our data in a couple different ways. Logistically, what data are available to us and when we receive them did change this year. And then in terms of content, with the 2022 release, we are focusing in on data that are important for our society as we continue to try and make sense of what happened as a result of the pandemic and do that work of rebuilding together.
Yeah, that makes sense.
So then in response to the COVID-19 pandemic, County Health Rankings has introduced two ways to view deaths attributed to COVID-19 in your community during 2020. These include the addition of premature deaths attributed to COVID-19, and we've added this to our usual table of leading causes of premature death. A premature death is any death which occurs before the age of 75. And we've also introduced a new COVID-19 mortality measure that presents the number and the rate of all COVID-19 attributable deaths in the county. This rate is age adjustment and the age adjusted, and the age adjustment allows for comparison across counties with different age structures. And this is something that's really important for a measure like this one, because we know that the risk of severe outcomes from COVID is really closely tied to age. So then we plan for these additions to remain available on county health rankings for as long as COVID remains a necessary focus of community health.
Yeah, and you mentioned that these data reflect deaths that occurred in 2020. Why do we not release real-time COVID data?
That is a great question, Erica, and it has everything to do with our approach to capturing and communicating community health. So the rankings data provide an annual snapshot of health, and maybe you could think of this like taking an annual professional family photo and maybe lining them up to watch change and growth happen over time. The COVID measures specifically come from the National Center for Health Statistics final mortality files. And these are informed by death certificate data, and therefore they're the most complete and final count for COVID-19 deaths in the United States. And this file does require some time to become finalized and made available.
Yeah, well, we would want that data to be accurate. So it is worth the wait to
Absolutely.
make sure that we're getting accurate data. And I know our audience is curious about the new data measures that we can expect with the 2022 rankings release. Can you share that and how those data are relevant to our vision of equitable communities in every county?
Yeah, absolutely. County Health Rankings has added 6 new measures to the ranking set this year, and we are just really excited about the doors that these measures open for deeper discussions of equity in communities. So starting out, we have added to our collection of income measures, a measure of living wage. Living wage reflects the local cost of living in a given community. This measure comes from the living wage calculator that was developed by Dr. Amy Glassmeyer and her colleagues at MIT. And you can find more information about the calculator and supporting documentation in our resource guide. A living wage is the hourly wage that's needed to cover basic household expenses. So if you were to imagine expected household expenses just stacking up, living wage is what the household needs to have just enough to cover anticipated needs like housing, food, medical care, taxes, transportation, and childcare. A living wage doesn't accommodate emergencies or vacations or savings. Living wage reflects that amount of income that's needed to cover these expected expenses.
And it feels like there's an equity discussion to be had here because different households are going to have different needs. Like a family with teenagers would need a larger food budget than a household with a single adult. I mean, my son is an adult now, but I remember being broke as all get out when he was a teenager.
And I think probably those days are coming for me too, Erica, as
That's
my
right.
kids get older. But yes, that's true. Something that's really neat about the living wage calculator is the ability to consider the different needs of a given household based on the number and the age of the people in that household. The living wage measure that we've added to the county health rankings data this year reflects the needs of a household for 1 adult and 2 children.
Okay. Which is the average, right? That's average family size, right?
And then continuing the conversation of economic security for families, we're also really pleased to introduce a measure of the local pay gap. The local gender pay gap. The gender pay gap is a ratio of women's earnings to what men are earning in the same place. This gap is often communicated as cents on the dollar. And in the US, women tend to make about 80 cents to each dollar of male peers. And maybe that doesn't sound like a lot, but over hours and weeks and months and years, that can really add up to something that's impactful. And this measure is important for community health because many households are headed by women, and the ability of these women to cover their household expenses will impact the local economy and will help keep children out of poverty.
Very, very true. And, some of you may have heard of Equal Pay Day. And Christine, as you know, last week, March 15th, in fact, actually marked Equal Pay Day in the United States. And like you said, that this date symbolizes how far into the year an average woman must work to earn what an average man earned in the United States the previous year. Now, sadly for Black women, Equal Pay Day will not happen until August. And for Hispanic women, not until October. Tommy's going to chat out some more information for you to learn more about Equal Pay Day. So thank you, Tommy, for doing that.
And thanks for landing those equal pay days on the calendar, Erica. I think it really brings home the size of this gap that we're talking about. The next 2 newly introduced measures are added to the collection of family and social support measures. The measure of childcare cost burden is defined as childcare costs for an average household as a percent of household income. Or if I were to say this another way, how much of the paycheck is getting eaten up by childcare expenses alone? In the US, childcare expenses consume about a quarter of household income, and this percentage is much higher in some places.
Certainly if a quarter of a household income is dedicated to childcare, that expense will cause stress in meeting other household needs. I mean, that stands to reason.
Absolutely. And Erica, thank you for naming that ability to meet competing household needs because it is a really important tie to health. Next, the measure of childcare centers is defined as the number of childcare centers per population under 5 years old. When quality childcare is affordable and accessible, it can enable parents and guardians of young children to participate in paid work and can provide children with that first introduction to structured learning. Quality childcare has been shown to provide children with lifelong benefits.
Yeah. And I know there are two measures related to education. So can we explore those next?
Yes, let's jump into these final two measures. The final pair of newly introduced measures is added to the collection of education measures. The measure of school funding adequacy is defined as the difference between actual spending per pupil and what is the estimated need to achieve US average test scores. This measure shows us a concentration of underfunded schools in the southern region of the US, with the most severe funding deficits clustered in this region of the US that's commonly known as the Black Belt in reference to the rich and fertile soil that's located there. These counties are where agriculture was most profitable for enslavers during the years that preceded the Civil War. In present day, these counties have a higher Black population compared to the rest of the US, and they are more likely to have underfunded schools. And then if we travel to the northern region of the US, we see a notable overlap between underfunded schools and places with higher American Native populations.
I hear you, Christine, noting that school funding is tied to both place and to race.
That is exactly right. And it leads us into our next measure, a new measure of school segregation, which describes how closely the racial and ethnic composition of a school reflects the racial and ethnic groups in the community. Research has demonstrated relationships between economic segregation, racial segregation, and academic opportunities. Recent statistics show that Black and Hispanic students are most likely to experience intense segregation in school and also most likely to be concentrated in under-resourced, high-poverty schools. And as a result, the teachers there are often less experienced and less credentialed and experience just a higher rate of turnover. And then for white and Native students, these students are disproportionately found outside of metro areas in the US. And in rural areas, these students can face high levels of segregation and really similar barriers to their peers in metro areas. These barriers put up blockages to success, including an introduction to high poverty within the school and the negative implications there for educational achievement. The negative impacts of segregation extend across race groups.
Yeah, Christine, I'm so glad that we have these new measures, particularly those in education. What's sad is that the outcomes, like in terms of test scores and stuff, these what we want them to, the outcome is expected to be the same, but the resources that the students need to get those test scores are not the same. So I'm glad that folks will be able to dig into these data in 2022. So, I'm going to be asking all three of the presenters this question. So I want to ask you, what are you excited about with this year's release?
Yeah, thanks for this question, Erica. As a society, as we continue our climb together out of the pandemic and those lingering implications for holistic community health, I'm just really excited that these data that we are bringing forward introduce new opportunities to focus attention and measurement on factors that will contribute to an equitable recovery by supporting the ability of individuals and households and communities to meet their essential needs in a dignified way.
Yeah, thank you so much, Christine. I'm so excited about these news measures. And as you said, they aren't just relevant to our recovery from COVID-19, but essential in making sure everyone has what they need to thrive. And so, for those of you in the audience, I know you are curious about when you can expect the new data. I promise we will share that special date at the end of the webinar. So stay tuned for that. And Christine, we'll circle back to you when we get to our Q&A session. And I'm also excited about some of the new What Works for Health initiatives that will be available over the next few months. So Michael, please welcome me back here at the mic. And can you tell us more about what we can expect?
Yeah, absolutely, Erica. So today I'm going to talk about 2 new What Works for Health products. And I'll start by sharing revisions that we're making to the current What Works for Health disparity rating, and then transition to talk about a new curated strategy list that we'll be publishing. And to introduce our new disparity rating work, I'll share the simple question that appears on this slide that we're often asked. What are evidence-informed solutions to reduce disparities and advance equity? To answer that question, we often point people to What Works for Health. What Works for Health is a product of County Health Rankings and Roadmaps and is an online tool to help you find policies, programs, and systems changes that make communities healthier places. I know many of you are frequent users of What Works for Health, but for folks who may be new, within What Works for Health, we offer 2 different ratings for each strategy, an evidence rating and a disparity rating. Evidence ratings offer a quick way for you to assess the strength of the evidence supporting a strategy. And our evidence rating has 6 different ratings, ranging from scientifically supported, the strongest evidence rating, all the way to evidence of ineffectiveness. The second rating that we offer is a disparity rating. And this tells us how likely a strategy is to address disparities between different groups. Essentially, how well does the strategy close gaps? As our understanding of disparities and equity has deepened, and as the field has evolved, we've identified opportunities to improve the current disparity rating to strengthen its orientation towards equity. So over the past year, our team has reviewed the literature and talked with experts to inform the revision. We've also talked with What Works for Health users, people like you, to make sure that we provide you with the information that you need to advance equity in your community. So our new equity analysis framework will help users more intentionally consider equity when selecting and implementing evidence-informed strategies.
Yeah, we often hear from community members how helpful that disparity rating is, Michael. Can you talk a little bit more about what we can expect as What Works for Health shifts from that disparity rating to the new equity analyst framework?
Yeah, absolutely. So I'm excited to preview what you'll start to see later this year in What Works for Health. So our new equity analysis framework will replace the current disparity rating section on each strategy. So even though we're sometimes limited by what the current evidence says about how well a strategy addresses disparities, this new framework acknowledges that there are decisions you and I make every day that can help advance equity in our communities. So this new section includes a number of different components. The first is just a revised disparity rating. And this rating will expand the number of ratings. And what's really important about this new rating that will roll out is that it names the strength or the type of evidence that led us to assign that rating. So for example, in the new framework, a strategy may be rated potential to decrease disparities supported by expert opinion, or it could be rated potential to decrease disparities supported by strong evidence. In addition to the rating, we're also offering a brief description to help you understand the evidence behind that rating. So we heard from experts and know from our own experience that a rating without additional context can sometimes lead to misinterpretation. So in our new framework, the description creates transparency about why the rating was assigned by summarizing the evidence, and it also names the groups for which the rating applies. The last 2 sections of the new framework really move us closer towards equity. So the first section that will be added, or another new section under the equity analysis framework, is historical context. And for us, understanding historical context and root causes of an issue is really core to our understanding of health equity. So it won't be possible for our team to provide a comprehensive history or root cause analysis for each issue a strategy is trying to address. But analysts will start to provide a summary to help you think more deeply about how well a strategy accounts for and addresses historical drivers of inequity. And lastly, a section that I'm really excited about is equity considerations. So this section gives our analysts an opportunity to apply their deep expertise about a strategy by writing a series of questions to help you engage with your community around equity. So questions really reinforce this idea that what works for health users influence how well a strategy addresses inequity in your community. And they also allow us to raise important considerations that are either not yet reflected in the evidence or to apply learnings from evidence that wouldn't typically be cited in the evidence of effectiveness summary.
Got it. Yeah, and you've already answered that question. I was going to ask you what you're most excited about, but thank you. I was fortunate enough to be invited to be a member of the internal team reviewing the new equity analyst, I keep saying analysis framework and what works for health. And I can tell you, if you're committed to implementing strategies with an equity lens, the analysis will be a valuable tool for you. And then, Michael, I know another way that what works for health is helping us think about equity is by turning a spotlight on America's racial wealth divide.
Yeah, that's right, Erica. So the second new product that What Works for Health will be releasing with rankings is a new curated list on racial wealth building. So this graph from the Asset Building Policy Network shows that in the US, white households have roughly 10 times the wealth of Black households. And what this graph doesn't show, because it's a point in time snapshot, is that the divide is actually growing. So wealth creates more opportunities for people to receive a good education. It creates opportunities to start a small business, to live in low crime neighborhoods, or to buy a home that's free from lead hazards. So wealth can help us access all of these things, and all of those things influence our quality and length of life. Wealth also provides a safety net that can protect us when times get tough. Mm-hmm. And although the connection between wealth and health is strong, the connection is not perfect. So wealth doesn't protect us or protect people from discrimination or racism, which we know also contribute to poor health. And because of these important connections between health and wealth, we're launching a new curated list, as I mentioned, of what works for health strategies that can help close the racial wealth divide.
And your team has already created other curated strategy lists like you did for, COVID-19 recovery. And I know a lot of work went into that effort. So can you share a little bit about the process of creating this curated list?
So over the past year, we've reviewed the literature and talked with scholars and practitioners to better understand why the racial wealth divide exists and what we can do to close or eliminate that gap. And although there are no single or simple solutions to close the gap, there are evidence-informed actions we can take to make a difference. So through this engagement with experts and literature, we've learned so many important things that we're excited to share with you over the next few months. And a few of them I'll share today. The first is that policies and practices created and maintain the racial wealth divide. So historical practices like slavery and redlining established the wealth gap, and current policies and practices like our tax code help maintain it. And why this is important is because this means that individual efforts alone cannot overcome these barriers. The second takeaway that I want to share with you today is that wealth is passed from generation to generation. So this is particularly important because it means that people are born into different levels of opportunity, but it also means that it makes it much more difficult for people to catch up because the divide is further growing. And lastly, just to really kind of make this feel more kind of practical and bring it home, in the US, many households build wealth through owning a home. And so although increasing access to homeownership by itself will not close or eliminate the gap, creating more opportunities for homeownership can make a difference.
Yeah, yeah. And what kind of strategies will the new curated list include?
Yeah, so this curated list of what works for health strategies really accounts for those historical practices, the things that I mentioned in the previous slide. So things like redlining and slavery and the tax code that established and maintained the wealth gap and reduce wealth inequalities by increasing income and assets, expanding employment opportunities, removing barriers to quality education, and increasing access to home ownership. So in addition to highlighting over 30 existing What Works for Health strategies, we're adding several new strategies to What Works for Health that we're really excited about. And some of these new strategies include solutions like universal basic income, reparations, baby bonds, and community development financial institutions. And as I mentioned, this list will go live with rankings.
Thank you so much, Michael. And again, we'll be releasing that date shortly. But Michael, I really want to thank you for spotlighting the racial wealth divide, because this is an issue that you all can expect to see CHR&R spend more time unpacking in the future. And we will circle back to you, Michael, just as soon as we get to our Q&A section. So thanks for joining us for that. And now CHR&R, as I said earlier, has a new team called the Communications Outreach and Engagement Team. And Beth Silver leads that multidisciplinary team of communications and public health specialists. Welcome back, Beth. And can you tell us what are some ways that this team is supporting our mission to grow community power to improve health equity?
Thanks, Erica. One of the fundamental pieces of moving data to action, as we like to say at CHR&R, is being able to communicate what we're learning, whether it's from the numbers or the strategies we rate for improving health outcomes and health equity. In other words, it's not enough that we know it here in the halls of the University of Wisconsin. We have to share that information with the people who are using it, and beyond that too, with the public. So there are two parts to that. First, what's the story? What do these disparate pieces of data mean? How can we ask questions of the data to spot trends, to find inequities, point out disparities, and connect that information back to the communities that make up the numbers and to the ways this impacts health? Second, how are we going to tell these stories, and who do we want to reach? We have a lot of avenues or channels. We write stories in our blog and post all kinds of rich content on our website. We produce data spotlights with interactive data and stories to provide context. We obviously produce the webinars. We communicate through our newsletter and in social media. We pitch stories to the news media so they can write about these issues. And now we're adding another channel, a podcast. So Erica, to answer your question directly, how does this support growing community power? I think of the communications portion of what we do at CHR&R as the sharing portion. We share the information we discover so practitioners, the people working on these issues in communities, can use it to inform their work, where to spend money, what needs attention. And then we also communicate it so we arm the public with information that will enable them to harness power for themselves.
Yeah, and tell us why our stories are an important data source just as the rankings?
Great question, Erica. I think of stories as the context. It's the way we make connections with the data and the strategies. And in some cases, it's the illustration. When we write about an example in a community, say Stockton, California, providing guaranteed income to its residents, it's an anecdote, true, but it's also painting a picture, filling in the colors and the lines. We're bringing the data to life. It connects what can seem like an abstract concept and draws place, people, and experience into the story. It's the difference between saying a number and providing the history and the context that led to that number.
Yeah.
I think of a case in Alabama in the early days of the vaccine rollout, and the data said that Black Alabamans were getting vaccinated at a lower rate than white Alabamans. The story, however, revealed something so much worse. Black Alabamans weren't avoiding the vaccine. They weren't living long enough to be eligible to get the vaccine.
Wow.
And according to County Health Rankings data, at least 83% of the state's Black population lived in counties where life expectancy for this group did not meet age requirements for the vaccine. That's because life expectancy among Black people in that area was less than 75 years.
Oh, wow.
You know, look at how that shifts our thinking from Black people didn't want the vaccine to Black people weren't living long enough to get the vaccine. It's devastating. You know, on the other hand, one of the beauties of stories is that they make our work accessible and hopefully approachable. We like to infuse equity in everything we do here at CHR&R. It's not just the outcome we're after. That means using stories and language that respect both the communities we're talking about and the audiences who are receiving this information. It means respecting readers' time, speaking directly, plainly, and at a level that makes sense to all kinds of different people, with compelling stories and on topics relevant to the people in the field and the communities that face unfair and unjust barriers to living well and living long.
Yeah, and what you described, Beth, is how equity is both a process and an outcome. And I am certainly very happy to be on this team and a part of this effort. And hey, is it just me? Or is it that drawing look a little bit like Bob Ross?
Might be right.
I love that, Beth. What can we expect to learn from our webinars in 2022?
Well, thanks to you, Erica, and to our talented webinar team, we have so much to offer this year. We're heading into May and June with webinars on the racial wealth gap. It's a topic central to so many of the inequities we see, whether it's in housing, education, health outcomes. It impacts everything. And what I like so much about your webinars and about this topic in particular is that we get to talk about the solutions, evidence-based solutions that communities and different levels of government could employ today to solve looming inequities. Beyond that, we'll tackle managing misinformation in health. We'll have a webinar on creating resilient rural communities, one on community power among Native groups, another on environmental equity and justice and the connection to health, and finally, community development anchored in racial and social justice, just to name a few. So quite an impressive lineup on the horizon.
Yeah, I would agree. And now for the icing on the cake, Bev, what are you most excited about for 2022?
Yes, something we're really excited about here. We're launching a new podcast. It's called In Solidarity, Connecting Power, Place, and Health. And the idea behind it is based on social solidarity. We're all connected in ways that impact our day-to-day lives and our fates, whether it's obvious or not. Eric and I are co-hosting the podcast, which launches next month, April. It's a conversation and an interview, usually about 25 to 30 minutes long. It's an opportunity, for our listeners to be a part of what will amount to kind of a kitchen table conversation that challenges assumptions and reveals truths and focuses on the biggest issues facing public health today. We've recorded 7 episodes so far, one to introduce ourselves and 6 more that cover different angles of the racial wealth divide. We were able to bring in some incredible guests, including our own Dr. Christine Muganda and Michael Stevenson. We're interviewing Donald Cohen, who has written a book on how in this country we've moved from public goods to privatizing everything. We also bring in Dr. Dalton Conley, who's a professor and author from Princeton University, and he's been writing on this subject for decades. We have Dr. Andre Perry, an author and scholar from the Brookings Institution, and we have Latricia McLaughlin-Ryan, who's the executive director of the Atlanta Wealth Building Initiative. So we'll come out with some more episodes this summer, and in the fall, we'll debut another mini-series on a new topic, which is where you all come in. We're open to ideas, so please reach out to us at countyhealthrankings.org or place your suggestions in the chat box now. We'd love to know what you'd like to learn about next.
Oh, thank you so much, Beth. And so there you have it, folks. 2022 is indeed so exciting. We are stepping deeper than ever into equity waters in solidarity with you. So now it's time for me to ask you the same question I was asking my colleagues. What new tools and resources are you most excited about? I'm asking James to launch a poll right now. Is it our new data measures? What about our new equity analysis in what works for health that will allow you to examine strategies with an equity lens? Or is it our new podcast featuring some of today's equity experts? Of course, if you can't decide, just check them all. And this is an anonymous poll. We're just curious what you think about the new materials that we are making available to you this year. So James, feel free to go ahead and close the poll. And thank you for your thoughts on that. So when can you expect all of this goodness to be released? This is when you can expect our website to be updated with new measures. So April is also the time that you can look for those new What Works for Health tools, as well as tune into our In Solidarity podcast. So make sure you mark your calendars for April 27th right now. And I know we've had to have some questions bubbling up in the Q&A box after this wonderful presentation. So Joanne, I'm gonna hand it over to you to let us know what questions have bubbled up.
Some questions. We have many questions, Erica. So our
Of course.
presenters did a wonderful job of getting folks to really start thinking about how they might use these wonderful new resources within the 3 areas that they covered. And so thank you all to those of you who had submitted questions. I will admit that some of these questions cannot be addressed within the time that we have, but are really more conducive to discussions. And so know that you can always reach out to info@countyhealthrankings.org if you need, if you want to just have a deeper discussion about some of the information you heard today. But I am going to go ahead and start. We have some questions queued up. And Erica, I'm just going to ask you to let me know in between the questions when we are at our final one.
Sounds good.
So Christine, I would love to invite you back. We have some questions. Folks are so excited about the updates and the new rankings release. I'm going to start with a question from Jean, because I think a lot of folks are wondering this. And he says, about the 6 new measures, are these used to calculate the overall county rankings, or are they additional data not used to calculate the rankings?
Thanks for this question. Yes, these will all be additional measures, which means that they won't be impacting the overall county ranks in any way.
Okay, thanks for that. And then Christine, I'll keep you. I have another question. Hila wanted to know, will the rankings have more race, ethnicity, county level data? For many of the current measurements, data don't seem to be broken down by race, ethnicity.
Another great question. So for all of the new measures that we are introducing this year, there will not be any new race disaggregations for those. There are some limitations that are in place based on where our data come from. And our team steps through a rigorous process to make sure that when we would be disaggregating any data by race, we're doing it in the most responsible way and making sure that these estimates are reliable before we put them forward. So all of these things contribute a little bit to the decision about whether or not race disaggregation would be possible for measures.
Thanks for that. And I do want to, there was another question that came in just about the lag between when data sort of comes out and when you incorporate it into county health rankings, the pool of data. Is that information available for each of the measures? You know, what the lag is?
Yes. So when you visit the county snapshot and you're looking through all of the measures that are available for your county, whenever you select a measure, you'll be able to see which data years are associated with that particular measure value that you are viewing at that time. All of that information is available on our county snapshots, and it does vary by data source, the amount of time that has passed between when we published the data and when it was collected.
Great, thanks so much. If I may, Christine, there's one more question, and this is really about the gender gap data. And Jana wanted to know, does the gender gap data account for women who work part-time or don't work to take care of young children, or does it only include women who work full-time?
This is another great question. So this measure is only including individuals who are working full time. So if an individual is caring for children at home and that means that she would be working part-time or not working at all in the paid workforce, her efforts wouldn't be included in this measure.
Okay, thank you so much. I think I'm going to let you take a break, Christine, and ask Michael to come back on and join us. So Michael, you really got a lot of folks thinking about what you presented in What Works for Health and the recent updates. And John wanted to know your thoughts about how does the racial wealth analysis accommodate or not accommodate households with undocumented immigrants?
Yeah, this is a really good question, and one that I won't probably have a perfect direct answer for today. So the data that we rely on, or the data that informed the bar graph that I showed for the racial wealth gap, comes from the Federal Reserve Survey of Consumer Finances. And this is a survey that's done every few years with a sample of households within the US. I'm not sure what the inclusion criteria is for if an undocumented family could participate in that particular survey. What I can say is that some of the solutions that we really highlight in the racial wealth building curated list, would apply to many different groups. And I think the solution orientation, although there might be some nuances around what might work best for an undocumented, family or community, there are things in the list that I think you'll find, meaningful and informative.
Great, thank you. And I actually want to invite Christine, Michael, please stay on, and Beth to join us, because I think some of the next set of questions, each of you could probably chime in on this. And Beth, you got folks really, really excited about the podcast. There was lots of great comments in the chat and some questions coming in. And I think, the next set of questions kind of relates to how do you take data, how do you take evidence-based strategies and stories to really move to action in the community? So JP really posed something very specific to tribal communities, and he wants to know your thoughts about how county health rankings data can be used for smaller communities such as tribal reservations to address health inequities and social determinants of health. And I would throw into that any insights, Michael, you and Beth, how about using data along with strategies and stories for these smaller communities that have maybe less than 5,000 people?
I'm going to let Michael start with that one. I think the What Works for Health strategies are on point.
Yeah, I think what I will add, and it's a bit of a two-part answer. So, the first is that the new equity analysis framework that we'll be rolling out later this year will start to call out some of the nuances among different populations, and specifically, some of the nuances or how effective a strategy is at closing gaps between, urban, rural populations, but also different, racialized groups, which would include Native communities. When it comes to the racial wealth building curated list itself, again, you'll see Native communities and rural communities referenced throughout those strategies, and we're learning a lot actually from those communities around what works. And so you'll see references within specific solutions where we're lifting that up.
Thank you. Christine or Beth, do you want to chime in about how to use these wonderful resources we just heard about to address some of the smaller communities, including tribal communities?
Sure. And coming from the data team, I'm going to give a data answer. I think I would say that whenever we're looking at data that is rolled up or summarized in some way, we have to remember that it doesn't represent the particular experience of every single individual within that group. And this becomes more and more important as communities get smaller, because a lot of variation can happen that just make those estimates a little bit harder to really hone in and pinpoint the experiences. So I'm seeing a lot of chatter in the chat, and I'm just going to amplify that. I think listening is a really good way to start. So we can begin with these data points that are summarized in the snapshot and look for places where we might want to dig in a little bit deeper, or something that might be a yellow flag or a red flag for us for health in that community. But the people who are living in that community, especially small communities, especially communities where individuals have been marginalized, their voices are going to tell us so much more than a number ever could do.
Right. Well said. Thank you so much. All right, this is a question for all three to chime in again. You know, when you think about the updates with the ranking, what works for health, and all the exciting things happening around stories in the podcast, what suggestions do you have for communities with low rankings who have also experienced a disproportionate impact from COVID and the opioid crisis in order of framing the issues?
Maybe I can start with this one. So all of the measures that we have put forward on our snapshot, and especially these newly introduced measures this year, are intended to lay this landscape of what is important for health. And these measures were selected based on what research has shown us to be true. So the measures are a good place to start when we're looking to build that case, and point to things that we might want to change in a certain community in order to bring more opportunity for health into that space. And again, I'll just reiterate that these measures that we're putting forward this year, we are highlighting them against the backdrop of what we know to be true for all communities who are working to climb out of the impacts of the COVID pandemic. So we realize their particular importance in this particular point in time for us.
Mm-hmm.
Yeah, for me, when I hear a question like that, I think back to the historical context kind of portion of our new equity analysis framework. And for me, there's a lot of commonality around some of the historical drivers of those inequities that communities experience. And, you know, for me, it's about starting conversations about what are some of those historical drivers of, things that result in low rankings, or, high overdose rates, or, poor outcomes from COVID. And starting those conversations, I think, can be really, powerful for decision makers, but also for, community members, as they can, talk through their experiences in their community.
Yep, the lived experience is so important. Thank you so much, both of you, and to Beth as well. And Erica, I know we need to move on given the time, and I just want to assure folks that if your question wasn't addressed, we will try to funnel them to get responded in some manner if you left your email address when you registered. Thank you so much.
Thank you, Joanne, and thank you all for, as they said, such excellent questions. And it was just exciting to know you were tuning in and really listening. We really would like to know your thoughts about today's webinar. And Tommy's chatting a link right now to a short survey, and we ask that you just click on it and save that survey until the end of the webinar and just complete it when you can. And we actually listen to your feedback. It's one of the ways that we choose the topics for upcoming webinars. So please be sure to complete your survey. I appreciate that. And, we talked a lot about, I told you how we were going to unpack this idea of America's racial wealth divide. And we kind of started the conversation today, but you can count on CHR&R's data, our What Works for Health strategies, and our new podcast as well to inform you on this topic. Like, how did we get here? How is wealth connected to health, and how strong that connection is? We're going to unpack all of that as well as solutions. So we're going to kind of bring all three pieces or elements together: our data, our What Works for Health strategies, and our new podcast in a two-part series that's going to start in May, and it's called America's Racial Wealth Divide. Now, you don't want to miss this series, and we will be sharing information about it on our website about how you can register for the webinars. Some of you were asking in the chat, like, how do I stay connected to this information? How am I going to get, know when the podcast is up and running? Well, this is how. Stay connected to us through social media. And we're now on LinkedIn. So happy about that. But also the newsletter. That is the best way for you to find out how you about our new webinars that are coming up and these new tools and resources and the dates on which they will drop. So make sure that you sign up for our newsletter. Some of you were here for us in the beginning when you had an intro. We actually going to have an outro as well. And you can use the QR code in that outro to sign up for our newsletter, or simply go to countyhealthrankings.org/subscribe. So I want to thank all of my wonderful colleagues for sharing their wisdom with us today. Be sure to mark your calendars for April 27th and check out your county's rank. Also, be sure to check out our new podcast, In Solidarity, wherever you listen to your podcast. Again, thank you for all the work that you do to create equity in the communities that you serve, and we will see you in May.